at the name of the type of the arrhythmia. Afterwards, we spoke about types of blocks, and we also spoke about how to interpret an ECG graph.
Any other? We talked about the description of arrhythmia. We talked about description of arrhythmia. And I said that for description, we have three phrases or words. So we could have the rate, determine how fast or how slow the rhythm is. We talked about the origin. Arrhythmia is being caused by. We have arrhythmia. What is the cause of the arrhythmia? So, area which is causing that particular arrhythmia. That is the origin. So the origin is there. And the pattern. The pattern is what will be shown. So we use this to describe an arrhythmia. So when I get to, I'll be telling you people something. When I get to, then when the number gets to about 220, just remind me that I'll be telling you something. So these are the three words that could be used to describe arrhythmia. So the moment we mention an arrhythmia, we should figure the source, the origin. We should figure the rate. It's all these. The rate, the source, and the pattern. And the pattern will be telling us. The pattern will tell us the source. The pattern will tell us the rate. So that is that. What did we learn under the pattern? What did you learn under the pattern?
So, under the pattern, we learned that there are different types of patterns that can be seen on the, that happen in anatomy. So we have premature contraction. We also talked about the relation.
The line is
flatter. Hello.
We have breaks in your line.
Hello, Dr.
Hello.
I was saying that under the we learned that we have the stop or premature contraction. We also learned about the relation after paroxysmal. So we have this kind of pattern under arrhythmias.
Casely. Casely, your line is, you are breaking. Mm-hmm. You learn. You learn. So how do we differentiate between flutter and fibrillation?
For fibrillation, it is fast but rhythm, while for the flutter, it is fast but regular rhythm.
The line is breaking. The line is breaking. Okay, so let's continue. So we did types of cardiac tissues. What did you say about the cardiac tissues? What did you say about the cardiac tissues? Types of the cardiac tissues. What did you say about the cardiac tissue?
We have two types of cardiac
Under the type of cardiac tissues, we have the fast channel tissues and the slow channel tissues. And under the fast channel tissues, we said that there are certain areas within the heart that have high density and fast sodium channel. Example being the atria and the ventricular myocyte, the bundle of Hess and the Purkinje fibers. And under the slow channel tissues, there are areas within the heart with low density of fast sodium channels. Example being the SA nodes and the AV node.
Mm-hmm. What are some of the characteristics?
Under the characteristics, we started with the slow channel tissues, and we said they have low density of sodium, fast sodium channel, and there are slow velocity conduction of impulses there.
Yeah, what? Come again about that, the characteristics.
Under the characteristics, under the slow, the slow channel tissues, they have low density of fast sodium channel. They have rapid spontaneous diastolic depolarization. And under the fast channel tissues, the characteristics, they conduct the conduction via these areas are fast, and they have little or no spontaneous diastolic depolarization. And they are rapid. It means they have little or no pacemaker activity.
Meaning?
They have little or no pacemaker activity.
Meaning? Meaning? All that you are saying, you are right. Meaning?
Dog, meaning they can't generate impulses by themselves.
So by their own, they cannot initiate what?
Impulses.
Impulses. That is the pacemaker activity. The slow channel tissues have that characteristics. In the diastolic state, they can spontaneously generate impulses. That is the pacemaker activity. But the fast tissues don't have. It's a little or no. So that is that. Let's do the electrophysiology. Electrophysiology. The ions, the behavior of these ions, which aids in the contraction, the behavior of these ions, which aids in the contraction. So, electrophysiology. Electrophysiology. Understand this, please. Understand electrophysiology. Electrophysiology, we are talking about the action potential of a myocyte. Action potential of a myocyte. So, action potential of a myocyte. Yes. You are not there. Thanks. So, the action potential of a myocyte. Who can tell me what is action potential of a myocyte? What is the action potential of a myocyte? What is action potential? What is action potential?
Sir, please, it's exciting repolarization and depolarization of the myocyte.
So we have this to be myocytes. These myocytes, there could be repolarization and depolarization. These two processes can occur. So, depending upon the energy level of these myocytes, it can contract. That is depolarization. And also, there could also be relaxation. That is repolarization. So you could have the two. So you want to know how does the electrolytes, the ions, electrophysiology behaves in this action potential. In the action potential of myocytes, we want to know how these electrolytes behave. And it's important for you to know, because when you know this, some of the medication that we are going to use, I want you to appreciate these things, because the medication would also be affecting the electrolytes behavior. By affecting the electrolytes behavior, it can prolong the refractory period. So this is a myocyte. And we want to know how, if this myocyte gets energy, how the electrolytes within these myocytes will behave. So the first thing I want you to know is that within the myocardium, we have channels. Within the myocardium, we have channels. We call them gated channels. Gated channels. It's gated channels, because these channels could be closed and these channels could be open. So we have these, this to be the heart. So we have these gated channels that connect outside to the inside, gated channels. Very important. These are the gated channels found within the myocardium, gated channels. And these channels contains those ions that goes through these gated channels. That's ions that goes through these gated channels. And the ions are the ions found within the myocardium. And depend upon the movement of these ions, depend upon the movement, there will be contraction. So we have sodium channel. We have potassium channel. And we have calcium channels. So these are the channels. The sodium channels, the potassium channels, and the calcium channel. So these are the channels found. And so when a myocyte gets an impulse, then there will be changes in the behavior of these channels in terms of movement. Some will be moving from the outside into the myocardium. Some will also be moving from the inside myocardium to the outside. So there will be exchange of these ions. And exchange of these ions will now cause the contraction. If you take an engine of a car, if you take it, we have the block here. Assuming this is the block. If you open the block, engine of a car, if you open it, we have pistons that moves like this. So when you spark the car, you'll be seeing it moving within the engine, moving like this when you open the engine. So these are the pistons. And the same thing, as this is moving within the engine, it will move the car. The same as this. When the myocardium gets energy, when there's an energy, myocardium gets energy, what happens is that electrolytes, these ions will be moving. Some will be moving in, some will be moving out. And the behavior of these will cause the contraction. The behavior of these ions will cause contraction and also cause relaxation. That is the electrophysiology. So what you should know is that the passage of ions across the myocyte. There's a passage of ions across the myocyte cell membrane. Passage of ions across. And this passage of ions across the cell membrane is regulated by a specific ion channel. This movement of ions across the myocyte cell membrane is regulated via a specific ion channel. So these are the channels. And there's a movement of ions within. Movement of ions within. Movement of ions that move in and out. Move in and out. Depending, if it's contraction, then certain ions will be moving. If it's depolarization or repolarization, then there will be change in terms of movement in and out. So that is that. The next thing that you need to know is that when a myocyte is at resting state, when a myocyte is at resting state, that is one part of action potential, repolarization state. When it's in repolarization state, what happens is that there's an energy. These myocytes will be having an energy. That energy is minus 5. This energy is minus 50 millivolts minus resting state. The resting state of a myocyte is minus 50 MV. That is so when you are even asleep, you have an energy. When you are asleep, you have an energy. When you have impulses being released from the sinusoidal node, these myocytes get extra energy. This will push these energy from minus 50 to minus 90 MV. So you have this as a resting energy. You have gotten an energy. It's the same as when a patient is in hypo. Then when a patient is in hypo, is in that state, resting state. The patient is lying down, is that resting state. And when you give the patient something, whether ice cream, whether sugar, that sugar becomes the energy receiving from my sinusoidal node. So the moment the patient gets this energy from the ice cream, from the sugar, these patients, because he has gotten an energy, and the patient could be standing as a result of this extra energy. And that standing up by the patient will be the energy that the myocyte have gotten. And they will be contracting. Now he has gotten energy, so the patient can run, the patient can sit. Because he has gotten energy. So when a myocyte gets an energy from the sinusoidal node, the impulses received from the sinusoidal node, and because he has gotten the energy, it is pushing the patient from the resting energy, which is minus 2, minus 90. There has been increase in the energy. When there's increase in the energy, what happens is that these gated channels will be open because we have gotten an energy, and there should be what? Contraction. So this is how the electrophysiology now starts. They have gotten an energy. This is how it starts. So the moment a myocyte gets an energy, impulses from sinusoidal node, the first channel that will be open is sodium. The first channel, please understand this area well. The first channel, the moment the myocyte gets an energy or electrical impulses from sinusoidal node, the first channel that will be open. So we have a myocyte. It's in a resting state. It has gotten impulses from the sinusoidal node. The moment it gets impulses, the first channel that will be open. This is action potential of the myocyte. The first channel that will be open is sodium. Sodium channel will be open. And what will happen is that there will be influx of sodium ions. Influx of sodium ions. Influx. So what will happen is that when we are talking about conduction in areas that have more sodium, the conduction is fast. So we'll be having a fast conduction. This will be the fast conduction. There will be opening of sodium ions. And that will cause influx. There will be more sodium getting into the myocardium. That's the influx. So when it gets to this point, the sodium influx will cease. There will be depletion of sodium ions. When you have this depletion of sodium ions at this point, the next channel that will be open is potassium. Sorry, it's calcium. Calcium ions will be open, channels will be open. So the moment sodium ceases, or there's depletion of sodium here, now we have influx of sodium. And the influx of sodium, when it's finished, we don't have any sodium ions outside here. All the sodium ions have moved into the myocardium. When we get to that, the next channel that will be open is calcium. Calcium ions will be open. And when calcium ions open, listen to what happens. Two things will be happening, but the first thing is what? Calcium. Calcium ions will be open. And there will be influx of also calcium ions here. Influx of calcium ions. At the same time, potassium ions will also be opening. At the same time, potassium ions will be opening. But there's something here. Calcium influx, because we are causing contraction. Calcium influx will also, one calcium influx, calcium opens, the channel opens. The influx will also be more. So more calcium will be released. And potassium will also be opening at this point. But here, potassium efflux. Potassium is moving from inside to where? To outside. We have potassium efflux and calcium influx at this point. But there will be more of calcium in there and less of potassium efflux. It will be starting like now you're pushing more calcium, but potassium efflux will be less. Then you'll be moving on. As you move on, because calcium started, the influx of calcium was high. What will be happening is that as we descend, calcium influx will be reducing. The potassium will be starting. The efflux of potassium will also start, it will start with small amount, and as we move on, it's also be increasing. And therefore, potassium will be gaining ground, will be increasing, whilst calcium will be decreasing. And a time will come at a certain point here where you have a plateau. And the plateau means that the efflux of potassium moving out, the amount of potassium moving out becomes equal to the amount of calcium moving in. So when we have a situation like that, we get a plateau. So we get a plateau here. At a point here, what will happen is that now the calcium here, calcium started with a high amount. And as calcium, as time goes on, the calcium content will be reducing. So at this point, calcium will cease. Influx of calcium will cease. And because potassium started with smaller amount in terms of the efflux, at this point, there will be some potassium still in there. So there will be efflux still of potassium. And this is the reason why it behaves like this. Anywhere that we have efflux of potassium, only then we have what? We have repolarization. So potassium efflux will give us the repolarization. Movement of potassium from within to the outside will give us the repolarization. So the action potential of the myocyte, so when a myocyte gets an energy, this is what happens. They get energy. The first channel that will be open is sodium channel. And the conduction via the sodium channel is fast. So you'll be getting these T. At this point, what happens is that the sodium ion ceases. The moment the sodium ion stops, the influx of sodium ion stops. The next channel that will be open is calcium channels that will be open. And when the calcium channel opens, there will be more influx of calcium. So calcium, because here and here, there's contraction. Here, there's contraction. As we are moving towards the plateau, the contraction decreases up to this point. So what happens is that here, there's still contraction. So what happens is the calcium channels will be open. The more influx of what? Calcium channels. At the same time, potassium, because it's the potassium influx that will result in what? Result in a repolarization. But because here we are at the peak of contraction, potassium influx will be less. So calcium will be opened and there will be more. And because calcium started with more, as we descend, the contraction, the amount of calcium that will be moving into the myocardium will be decreasing. As you move, it will be decreasing. Then the potassium started that small amount. Then as you move on, potassium will also be increasing. Once calcium is decreasing, potassium will be what? Increasing. Please, can you mute?
Hello, Dr. Takra.
Hello.
Please, he asked us to remind you to say something if we're about 2:20 on the call.
I don't understand why you are mute and be talking. So we are mad. Do you have any problem? Let me.
Hello,
Wow.
sir.
Do you have any problem? Your hand? You have raised your hand. I don't know whether you have any.
Oh, sorry,
Let,
sir. I was on mistake.
let me warn you about this. Yesterday, I met a student and he was saying that this is something I want you to be careful. The student was telling me this, that the topics I am teaching now is what they should concentrate. I told the student I have to inform you this. We are supposed to cover, listen, we are supposed to cover wider spectrum because we don't know. We don't know the areas coming. So to cover all these areas, I want you to learn your diabetes. If you pick your diabetes, you should learn the type 1, type 2, complications of diabetes. Learn hypoglycemia. You learn DKN. So you may not know. I don't want you to think that because you are doing these topics, getting to the ending of this, so you would spend your energy on these topics because we don't know what is coming. On my part, what is coming, I've done it with you. But you want to be sure such that other areas, the other lectures, you also be getting because we don't know what's the upset questions on. So the fact that I'm teaching atrial fib or arrhythmia this time does not mean that these are the topics that you should spend your energy on. Spend your energy on every topic. I'm getting a lot of stories. Some are having about 25 topics and they are saying should learn about A, B, C, D. And when it gets to this time, it's so big. The energy that you put on arrhythmia, put the same energy on heart failure. Because you could be asking you simple questions on heart failure. Could be asking you simple questions on heart failure. The energy that you are spending on the topics that I'll be doing, spend the same energy. You could be asking you simple questions on coronary artery disease. Simple. The way at times you think, it comes simple question, then you are wondering. Simple questions on coronary artery disease, not big question. Some are so anxious, and because of that, they are rushing through the topics that they are learning. Rushing through the topics that they are learning, rushing through. At the end of the day, you rush through, you come back and realize that nothing is there. The funny aspect is that you'll be there and your friend will call you and ask you a question. If your friend is learning, assuming your friend is learning about poisoning, and he asks you this, or your friend is learning about hypoglycemia, and he asks you something, you're also learning about different things. Then you feel some way, hey, so I'm shallow. I don't know this. You'll be rushing. You're learning here. You have your own program. in terms of your learning. And this is the way I want you to learn. When you learn a topic, just ask yourself, just put, today we have learned about, we are learning about arrhythmia. I don't know the topic that you learn. When you, after learning, just ask yourself questions. If they ask me about causes of what I've learned, what will be? What are the medications? What are the side effects of these medications? What are the doses of these medications? Question yourself. So let me do a try and say I'll come back to this. Let me do a try. Steve.
Hello, Doc.
Who's Ruth? I'm Koma.
Yes, I've muted it here.
So, Steve, what did you learn today, this morning?
Okay, Doc. Yes, I was going through my previous notes. So I was going through my UTI notes this morning.
So, UTI, I want you to just ask yourself questions about UTI, what you learned about the UTI, and see whether you can recollect the things that you learned.
Yes, please.
You so ask yourself, I don't want you to just be reading it. At the end of the day, the moment you go to the next topic, then what you read initially becomes. So ask yourself some questions. What you read today, and see whether you can answer those questions.
Yes, please.
Okay.
Please, should I ask right now?
Ask yourself right now.
Okay. Is nitrofurantoin effective in the management of pyelonephritis?
What you learned this morning, not what you learned this morning.
Yes, please.
Okay, so ask yourself.
So I asked, is nitrofurantoin effective in the management of pyelonephritis?
Mm-hmm. Then you try
Yes,
whether
try
you can imagine. Hello?
Hello, Doc.
Yeah, so you try whether you can answer. Yeah, something that you read. You
Yes,
ask
please.
yourself, then you try whether you can answer. Then you go back
Yes, please.
and ask yourself. So you are questioning yourself. The likely questions. After reading it, the likely question. It could be urethritis. Go ask yourself, oh, so what is urethritis? What are some of the organisms that are implicated in urethritis? What are the risk factors? What are the clinical manifestations of urethritis? Then you'll be asking yourself these questions. Then you try to answer, put the book aside, and try to ask yourself, cystitis. You ask yourself, what are the clinical manifestations, the organisms implicated? How is urethritis different from cystitis? Please ask yourself and answer those questions. You can have about 10 minutes to do these things. So after reading it 1 hour time, you ask yourself these things and you try. If the ones that you couldn't, you go back and quickly search it, I can get it. Hey, it's difficult. The professional exams is difficult and it's stressful on you. Stressful. I don't want you to think that, hey, the topics that we are doing at this time the topics coming, so you spend your whole time on only these topics. We did Rena, because the MCQs will cover every. I'm telling you, the MCQs will cover heart failure, epilepsy, coronary artery disease. You'll be picking one or two from these sessions. Therefore, when you are reading, make sure you read well. That is why we are doing this. If it's left alone, what I'm supposed to, the question I've left alone, I would have stopped. I may not know whether IBD will come. Somebody could set questions on IBD. That is a difficult aspect. So please, coronary artery disease, simple questions on coronary artery disease, heart failure, hypoglycemia, those diabetes. Please, I don't want you to concentrate on arrhythmia. Then you think that because I'm doing arrhythmia now, arrhythmia will come. Arrhythmia could come. It will not come from me. But you need to know arrhythmia. You need to know arrhythmia. I may not know if somebody sets question on arrhythmia. Last time they had cancer medication. So you brush through cancer medications. Just look at cancer medications, their side effects, you brush through. Last, we had STDs. We had DK, just the receipt. We had DK. The problem is the way you answer questions. Some of you will answer questions and you'll be writing unnecessary things. Some simple things. You'll be writing unnecessary a lot. Then you come back and say, hey, they have fooled me. I didn't understand them. You people don't know. At times, some of us will just be giving you marks. Like this. There was a question about just the risk. There was a question about risk factors of decay. You were writing risk factors: age, sex, gender, and co. Sedentary lifestyle. And the same person will say that, hey, I've forgotten it. So we are learning the energy that you put on this. Put the same energy on the IBD. Put the same energy on diabetes. Put the same energy on heart failure. Put the same energy on hypertension. Put the same energy, please. I don't want you to think that because I'm doing this, and these are the areas. When a person told me this, I'm saying, wow, if I don't say something, you would be spending your whole energy on maybe arrhythmias and the topics that I'll be doing. Please spend your whole energy. We did UTI. We did benign BPH. We did a BP, benign prostate hyperplasia. We did it. You did it with Ishak. Study that. Every area that epilepsy, you should know. Certain medications, certain type of epilepsy will not. You should know if a patient comes with this type of epilepsy. These are the drugs that we can use to manage. Certain type of epilepsy you cannot use If a patient comes to say absence seizures, you cannot use certain medication. So you should know. So I don't want you to think. That is the word I want to say to you. I don't want you to say that I'm doing arrhythmia this time, and therefore arrhythmia is coming. The energy, put your whole energy in every area. And ask yourself, some of you, fear is killing you. Fear, anxiety is killing some of you. Anxiety is killing as if you don't know anything. You see their faces as if they are going to die. When you learn, take your time. When you learn, you have learned that is what I'm learning this. I'll not go back. I'm learning this. I'm not going back. Learn it, please. Okay. You get it. You get what I'm saying?
Yes, sir.
Okay, so let's continue. Because I want to finish this and talk about the drugs. The drugs. Then the last thing that we do under arrhythmia is you do. I may not know whether somebody would set questions on them. We don't know. Trust yourself. I don't like you to now tell me that if you assess yourself, it will be about 40%. It will be about now you should be hitting at 60% in your learning. The laws and the clinical. Make time for the laws. Make sure the laws you are learning, especially the pharmacy active. If you don't learn anything, the pharmacy active, you should. You learn the pharmacy active, you learn the other laws, but your energy should be on the pharmacy active and learn the other laws. Okay.
Hello, Sam.
Mm-hmm.
Sam, please, how is the grading for the GPPK done?
Grading like
the required pass mark for each section.
basically we have two areas, but we have three. Basically, we have the clinical and we have the laws. That is the basic thing. Some of you will fail because of just one thing. Some of you will fail because they will do well in the clinical. They can get about 70%, 80% clinical. There was a guy I because of the way the guys, the first time he did well, the Lords in the clinic. I didn't do well on the clinic. The second time, what happens is automatically, if you fail in one, you automatically have failed. The other time, because he did well in other side, he didn't learn that side well. When you fail one, you should be getting 50% each, 50, 50 each. So the laws, the theory, and the MCQ, you should get 50 for the laws. The clinical, the theory, and the MCQs, you should get also 50%. That is half. And these, when you break it down, it will be 40, the orals, 20. And the orals is there to push you. The orals are there to push you. So the orals, If you organize yourself, you can get marks there. But the very important area is to make sure you get half of the laws. The laws will be having the theory and the MCQs. The clinical will be having the laws, the written part and the MCQ. This combination should give you should be able to get half of the marks. Also, this one, you get half of the marks. That is what we expect you to. So please, in your learning, people are failing, not just because they didn't do well at all. Just that they did well in one area and fail in another area. We call it automatic failure. They'll fail you.
Doc.
Mm-hmm.
Please, so the 60% that is stated at the website doesn't apply. So it's actually 50.
It's 50-50.
Oh, okay. Thank you.
50. Make sure the reason I'm saying 50-50 is that you should be able to have even the clinical and what? And the laws. When you fail the laws and you get the clinical 90%, automatically you have failed. Last year, a lot of people failed and we had to beg. About almost 33 people failed because of this automatic. We had to beg and then so this is what you should have at the back of your mind. If assuming, take this from me, assuming the lot is 100%, I'm supposed to get what? 50. Assuming that the clinical is 100%, I'm supposed to get what? 50%. When I'm able to get 50-50, I break even. I'm through. The orals, 20%. Overall, the orals will be 20%. And the orals, you will go through because you're dressing and under current affairs, those things should give you something. But you people are not afraid. You are afraid of the orals even more than the written. Don't be afraid of the orals at all. Just know your shortcomings in the written shortcomings. And you learn about current affairs in the orals, current affairs. The laws, the same laws that you could be asking, the same clinical that we asking you those things. So you shouldn't be afraid at all about the orals. And that is what you are not even afraid about the written and MCQ. You are afraid more about the orals. You should be relaxed there. Because it's easier getting marks over there. So put this on the back of your mind. It should be 50, half of the laws, half of the clinical. You should have this at the back of your mind.
Yes, please. Thank you, sir. Sir, please, can there be an instance where someone will pass both the law and the clinicals and we feel for the orals?
What I'm saying is that orals, hardly will somebody fail in the orals. It's hard. Very, very, very. I'm telling you, it's very. Because you're dressing. That is why we are saying you should appear. I don't know who is also circulating this. As if everybody, the ladies' choir should also be in suit. The guys, if they appear in suit, fine. But everybody, I'm told the ladies cry, they are going for suit. If you're going for suit and you can afford, fine. But you should appear formal. We give marks on the dressing. Marks are given on the dressing. Marks are given on the confidence, the way you. Some will be coming and as if they'll be shivering. It happens to all of us. Interview because you don't know where it's coming. But we try to calm you down. There's little mistakes that some of you, especially the guys, you do. When you come, buttons, your coat. When you button and you sit down, loose. Don't just sit there with the buttons on. You have to. You'll be giving marks in all this, your confidence level. So it will be difficult for. If I ask you one or two questions and you get it wrong, doesn't mean you have failed. No. Because you'll be asking a clinical question, you'll be asking you. So it will be very, I'm saying this, very, very, very difficult for somebody to fail in your eyes. Very, because your dressing will give you something. The way you appear, the way you talk, how bold you are, the way you answer questions, will be giving you marks. So if you ask about 2, 3 questions, you're able to say 1 or 2 correctly, marks will be given. But I warn you guys, some of you like talking too much, and some of you wants to impress. You want to impress. This is what some of you does. Something that could go straight to the point. Then be talking, want to impress, want to. And you'll be mentioning jargons that's when the follow-up questions are being asked. It becomes a problem. So I keep on saying that if I am saying anything, the follow-up question, I should be able to answer the follow-up question if I must. So organize yourself for this. Don't let fear take the lead. Don't let anxiety. You have learned about UTI. If a question is coming, it will come from what you have learned. If it's diabetes, it will come. Heart failure, it will come. Coronary artery disease. So what you have learned, what you have been taught about coronary artery disease, it will come. But you think, the way you think too deep. Then questions will be coming. From just surface questions will be coming. Then you will be. The last thing I'll say before I continue is that learn to apply. You want straightforward thing. Learn to apply. There was a question about these ACTs. And these ACTs, they were one of the past questions we were asking about which diet would be appropriate when you are giving ACTs. And was I talking about biscuits, talking about certain. This is application. So please take your time. Don't let any friend of you, don't let those people disturb you. You have your program. Learn. Follow your program. When there's a discussion, and the discussion, this is what you do a discussion. Organize yourself. We are learning about these topics. Then you go and do a discussion on that. You look for questions. Tie your hands. When you make it open, you will not appreciate this. Get topics. Today, we are learning about these topics. We'll be discussing about these topics. And you do a thorough discussion on those topics. If you take diabetes, you think that diabetes will be good. Take diabetes, learn, discuss about maybe the complication of diabetes. Discuss about that. Hypoglycemia, BP, diabetic processes. You discuss. You will go through. It depends on the way you organize yourself. You are looking at your friends. Because of that, times you get so disturbed. You think that you don't know. You have learned so much. You have learned a lot. And when you sit, it will come. It will come. Okay, so let's go back to.
Thank you, teacher.
Go back to.
Please, one last question. Please, for GPPQE objectives, are we sitting for 100 MCQs or 150 MCQs? And I want to find out what's the time in total to complete both MCQs and written.
We have 3 hours to do that. 3 hours to do the whole paper. So 1 hour will be for the written. 2 hours will be. And this is the way they have arranged the questions. That is why we need to be fast. My worried about you guys are students are failing because of the time. That is my worry. Students are failing because of the time. So for the MCQs, you have ordinary MCQs where it will be straight. They're asking you, if we ask you, okay, we have, maybe you have spironolactone. Regarding spironolactone in heart failure. Then you tell you it A, reduces mortality. B, this is the raw MCQs. There's another set of MCQs that comes with what? That comes with ACEs. So we have a case. And that case, you read the case to answer the MCQ question. Do you get it?
Yes, sir.
So you'll be getting cases. And out of the cases, there will be those MCQ questions. There could be multiple completion. Fine. That will be, so that is also there. Then you have the theory. You get it. So you could have 5 short cases. Then you'll be using 5 short cases to answer. So there will be about 5 cases with, say, 5 cases. Each case is coming with 10 questions. It means you need to read. You're reading, you have to be fast in your reading. This is killing like some of the students who, before you analyze even the case, then there will be time. Time will be gone before you analyze the case. So what I want you to do is that This is what I wanted to do, especially face to face. You set questions for them. You time yourself. You could even have the past questions that you are discussing, those past questions that you are discussing. You could time yourself. Let's say these questions, 100 MCQ questions. Let's time ourselves. Let's see whether 100 MCQ we can use 1 hour or you can use 40 minutes to answer. You do that. So it shouldn't be all the time that you should go and do a discussion. You should learn to time yourself. You have a theory question, you time yourself, whether you can use. The time is killing most of the students. And because they'll be rushing and be shading. They'll be shading in there just to leave the thing where they will try to shade and put down something. So there's MCQ. So you'll be getting 150 MCQ, 100 MCQ, and the cases will be 5. Then you'll be getting the written. So in both, the written will be 1 hour, the MCQs will be 2 hours. Okay, enough of that. Are you okay?
Sir, please, the number of questions for MCQ.
If you go and it's 1,000, you will do. Oh, or you will not do.
I'll do. I have no idea.
So what's your problem? All that I'm thinking about is the time, the way you can move fast. It's the time. And in shading, please, in shading. In shading, be careful. Your scantron, the scantron that maybe you are using at school, the numbering could be different from. So be careful about the numbering. I've seen 1 or 2 complain about the numbering. They made mistake because of the numbering. So please check the numbering. And at times you decide that this question 4 is difficult. I will not do question 4. So you would mark question 4 that you come back and answer it. If you don't take care, what will happen is that in answering question 5, you bring it to question 4. Anything can happen when you are tensed. So I want you to do, this time should be a relaxed time. Do that. You have a lot of fast questions. In terms of connection, you are good. You have a lot. Sit and time yourself. Time yourself. You can decide that let's time myself for these questions. So we do 1 hour, 1 hour. Then after you have finished, then you can discuss and mark it and see. Okay, so don't worry.
So please, in terms of like answering the questions, are you supposed to answer the section A or the section B first? And will the paper be taken away from you before you continue with the other parts? How is it done?
There's one problem here. There's one problem that students are always the lady, but because the lady was good, passed. This is what was happening. We have 2 books. Let me say this. We have 2 books. We have blue and we have yellow. The yellow what? There will be instruction. Listen to the instructions, please. Normally, the yellow is for the theory, it's for the clinical, and the blue is for the laws. Please, when you go, I am saying this here, but when you go, follow the instructions. They will be talking about this, do this here, but at the end of the day, you always exchange these. At the end of the day, you do that. MCQs will be done first. The theory will follow. What I'm saying is that when you get there, there will be instructions. So if I say this A now, and they go and they tell you, do this first, it's just following what? Instructions. So when you get there, listen to the instructions, please. I'm saying this based upon the instruction. So I will tell you A today, don't take it as. All that I'm saying is that you go there with that open mind and take instruction. When you get there, they will tell you, do this. When you finish, they will come and take the papers. Then you do follow the instructions. So I don't want to say A today, and you take that A and go and do something different. And you tell me at the end of the day, Dr. Takwa said this, please. There will be instructions about the way the people should. And anytime the instructions are given, just go there, listen to the instructions. You get it?
Yes, please. Thank you.
I don't want to be telling you this is what is done. This is what is done. If you go and there's been a change, it becomes a problem. But the instructions will be given. Please, when you say clinical should be in this booklet, follow this simple instruction. When you say the laws should be in this booklet, follow this. You get it?
Yes, sir.
Okay, so
Thank you very much, sir.
my users, Matthias, are you okay?
Yes, please, sir.
Okay, so take this. This is how ions exchange. When you have myocytes contracting, this is how the electrolytes behave. The first channel that will be open is what? Sodium. The sodium movement is fast, so there will be a steep. So at this point, let me go to this side. So at this point here, there will be no sodium influx. It will cease. The moment sodium influx ceases, what will happen is that calcium will be open, and the influx of calcium will be more. At the same time, potassium channels will also be open. What happens is that potassium channels, when it's open, the efflux will start from small amount and you'll be building up. Please hold on for me. Hello. Hello.
Hello, Doc.
Okay, so the calcium and potassium will be open, but calcium, when you are talking about calcium, you are talking about efflux moving out through the gated calcium channels. And sorry, potassium is efflux through the gated potassium channel, and calcium will be influx. So at this point, calcium will be moving in. An amount of calcium moving in. Calcium will start with, it's like you are running race, and you start with that, your whole energy you start. Somebody will be starting also building up. You want to use your whole, the strength that you have to take up. Somebody can also be using and also be building up. So potassium will start with smaller amount in terms of the efflux, and calcium influx will also be more. So at a certain point, because calcium starts more, so as the calcium, the influx, the contraction is going on, the amount of calcium influx will be reducing, So reducing from here, reduce from here. And because potassium efflux started less, also be increasing, efflux will be increasing to a point that they will be having a plateau. When they get to a plateau level, it means that the amount of potassium efflux will be equal to the calcium influx. That is where we get a plateau. And when you get to plateau, still there will be contraction. But what happens is that the calcium will be decreasing, and potassium will be increasing. Because potassium started with less, calcium started with high. So at this point, there will be no influx of calcium at this point, but you'll still be having some of what? The potassium efflux moving out. So from here, there won't be any, from say C to D, there won't be any of, so please, this will help you also in the management. This will help you also in the management. This will help you in the management. Because the management talks about the electrophysiology. The medication also talks about the electrophysiology. Okay, so from C here to D, there will be only efflux of what? Potassium. This efflux of potassium here will cause what? Will cause repolarization. So if this is the start in the resting, if this becomes a resting potential, this will also come. So we'll be having a graph like this, where this will be minus 90, and this will be minus 50. Please, is it clear up to this point? This is electro action potential of what? Of the myocytes. Action potential of the myocyte. This is the way electrolytes behave in the cyclic repolarization and depolarization. Any question about this?
Dr. Tasako, Can you re-indicate where the minus 90 and the minus 50 is?
Minus 90 is here. Minus 50 is that resting now. There's a resting energy. This is minus this. When it gets energy from here, it's the resting. So we have this. You have here minus 50. We have here minus what? 90. So this will be minus 50. This is where you have the resting. So getting energy, when it gets energy from here to 90, then there will be this. There will be opening of sodium, and that will be steep. When sodium opens, conduction will be fast, and there will be this. Then you'll be having this. Then you'll be having this. See? Is it clear? So there will be this repolarization. That will get to what? That will get to the resting stage. So here is sodium. Sodium, and this is depolarization. And here is sodium influx. At this point, sodium will cease, influx of sodium will cease, and potassium will be open. Calcium will be open. The influx of calcium will be more, and efflux of potassium will be less. This is where they got the energy. Resting, they got the energy, and there's these action occurring. So this will come to the resting potential. Is it clear?
Yes, please.
Okay, so let me quickly go through this with you, the medications with you. Then when you finish the medications, then I will do the atrial field, and that will be all. I will do the atrial field, and that will be all. Because normally it's the atrial field that comes. If a question will come, it will be the atrial field. So treatment of arrhythmia. Medication that I use, we have other treatment where we have a cardio conversion where they put something on the chest. Defibrillation. They have all these, but I will not be talking about those things. I'll be talking about area. Because of time, I'll be talking about area, the medication. So drugs for arrhythmia. This is drugs that we use for the arrhythmia in general. Drugs that we use for arrhythmia in general. Then we narrow it down to the atrial field. We call it today because if you have atrial field, you have atrial flutter, you have ventricular fibrillation, ventricular paroxysmal, and all these are there. But when you have the basis, then when you pick one of these, it becomes easier. But because of time is not on your guys' side. So you learn about traffic issue about the basis of arrhythmia, first degree blood, action potential, refractory period. You should know. So let's talk about the drugs. So, arrhythmic medication, anti-arrhythmic medication are grouped into four main groups, or four main classes. Anti-arrhythmic medications are grouped into four main classes. And we call it VWC. VWC. Who can tell me this VWC?
Vaughan-Williams classification.
So VWC is Vaughan-Williams classification. And this classification, listen, this classification is based on their dominant cellular electrophysiological effects. These classification is basically depends on the cellular electrophysiological effect. How these medications will affect within the heart. So we don't have certain medications like digoxin is not part, adenosine is not part of this classification, because these class of medication predominantly affect the electrophysiology. So there's a dominant cellular electrophysiological effect. So this is what VWC. So it's not this class. It's not whole in the sense that you could use other medication like adenosine, like digoxin, but this will not be. This adenosine, this will not be under this classification. So that is that. So under this VW classification or VWC, under this classification, we have class. Please, this is area that you need to understand. It's difficult to understand this area, especially class 1. Very difficult to understand. So I'll be asking you more questions about class 1. So class 1, we have class 2, we have class 3, we have class 4. So VWC are grouped into 4 main classes. They are grouped into 4 main classes. So we have class 1, we have class 2, we have class 3, and class 4. So we have class 1. Under class 1, we have class 1, class 1, class 1A, class 1B, and class 1C. Okay, so class 1, they are called sodium channel blockers. Sodium channel blockers for class 1. The general name for class 1 is sodium channel blockers. Who can tell me another name for class 1? Name for class 1 is what? Another name for sodium class 1, which is sodium channel blockers. It can also be called
Membrane stabilizers.
it can also be called membrane stabilizers. So membrane stabilizers. So sodium channel blockers or membrane stabilizers. So this is class 1. Let's finish with the class 1 because the most difficult area. And we'll be moving on to class 2 and class 3. Okay, so what are examples of class 1A? What are examples of class 1A?
Procainamide.
So class 1A is what?
Procainamide.
Procainamide. So procainamide. Procainamide. Any other?
Quinidine.
So quinidine. Quinidine. Do you have any medication? Any other for class 1A?
Disopyramide.
So disopyramide. So disopyramide. Disopyramide. So these are class procainamide, quinidine, disopyramide. Class 1B is what?
Linocaine.
So we have linocaine. And what's again? What again?
Mexaretin.
So we have mexiletin. Yeah, mexiletin. Mexiletin. So class 1C. Examples of class 1C.
Flecainide.
So flecainide. I'm doing this because of the MCQs. You may not know. Flecainide. Flecainide. Any other?
Propranolol.
No. Propafenol. This is not common medications. This is not common medications at all. So if I ask you how it's flecainide given, you can tell me. How is it given? Becomes a problem. Why? Because it's not common medication. That's maybe the cardio, when you go to cardio centers, these will be common. The cardio centers will be seeing this because Bahamas they'll be getting a lot of these arrhythmias. Okay, so why these differences? Now, listen, we are talking about channels. This is sodium channel. And this class would block sodium channels. And sodium channels are found in where? This class of medication will block sodium channels. And sodium channels are found in where? Can you hear me?
Back inside the bundle of things, ventricles.
The reason why I said it's very important to know all this is that now class 1 medication is affecting sodium channel. Where do you have sodium channels? We have sodium channels in atrial And therefore, if a patient comes with atrial something, ventricular something, then I'll be okay when I'm giving this class of medication. Because over there, the density of sodium channels are high. Please, do you get it? Do you get it?
Yes, please.
So if a patient comes with sinus problem, sinus tachycardia, you will not be comfortable giving what? Giving class 1 medications. Are you appreciating why you need to know certain things? Lies.
Yes, please.
The patient comes with sinus tachycardia. Will you recommend that you should give class 1 medication too?
No,
Will
please.
you? Why no, please? Why no, please?
So from yesterday, we learned that at the synovial node, it has low density of fast sodium channels. So these medications wouldn't be needed for sinus tachycardia.
So sinus tachycardia, you will not be doing this for sinus tachycardia. Because the sodium channels over there are left. It will not be effective. So I'm saying that this is the way we do to understand medications in what? In the. Why this classification? Who can tell me? This class 1 is subdivided into class 1A, class 1B, class 1C. Is subdivided into this. Who can tell me why this classification into 1A, 1B, 1C?
Please, I think, the binding of the various medications to the sodium channel. So I think for each class, the strength of the binding to the sodium channels differ.
Good. So you are right. Understand these things, but I am going to use the references will not be saying. You went straight to the point. But when you read, they'll be using different things. That's why I'm saying that when you understand and you go back and you are reading from the books, at times, because you understand it's this, when they use any term, you appreciate this. So these classes, class 1A, class 1B, class 1C, these are done based on the kinetics of the sodium channel effect. The kinetics of sodium channel effect. If they are saying this, if you don't take care, you will appreciate this. But if you use what your colleagues said, the binding effect. So, class 1 drugs are subdivided based upon the kinetics of the sodium channel effect, the kinetics of sodium channel effect is important. The binding effect. The binding effect. So let's learn about the binding effects. So we have class 1A. So let me start from class 1B. If I start from A to B, it will be somewhere you won't appreciate this. We talk about class 1B. If I say class 1B has a fast kinetics, I'm saying that it's subdivided based upon the kinetics of the sodium channel effect, the kinetics, the binding effect. It binds to the sodium channels. And if there's a binding effect, how long is that binding? How long are we going to sustain it? The binding effect. If the binding effect is not sustained for a longer period, then the drug is not effective. It's not potent. If the binding effect does not take longer time, the kinetics does not take a longer time, then the drug is not potent. So if I say class 1B, those medications, they have fast kinetics. They have fast kinetics. So class 1B, this class, they have fast kinetics. What does it mean? Fast kinetics. What does it mean? So the reference, some of them will be using this term, fast kinetics. What does it mean? If I say class 1B has fast kinetics, what does it mean? Can you hear me?
Doc, I'm trying. It means they block the sodium channel quickly, but it can't maintain the blockade.
So that is that. There's a blockade that you said, but in terms of maintaining it is fast. It just loops. So that is the fast kinetics. So if you don't take it, you won't see any effect. It just blocking. There's a fast release of that blockade. So we say fast kinetics. Fast kinetics. Class 1B has fast kinetics. It means that it's not able to maintain that blockade. Quickly, we have a blockade and quickly release that blockade. So that's the fast kinetics. There's no, it's seconds. And because of this, you won't be seeing this effect on the ECG. The effect will not be seen. The effect will not be seen because it's fast. Class 1C has a slow kinetics. 1C has a slow kinetics. What does it mean? A slow kinetics. Class 1C has a slow. So B has a fast kinetic. C has a slow. What does it mean when you say slow kinetic?
So it takes time to bind onto the sodium channel, but when it does bind, it lasts for a longer period.
It lasts for a longer period. Good. It lasts for a longer period. And therefore, when we have a drug behaving as the slow kinetics are more potent. Fast kinetics are not potent. So class 1C medications are more potent. When there's this binding, they are able to hold on. So fast kinetics are not potent. Slow kinetics are potent. Class 1A. Class 1A has intermediate. It has intermediate kinetics. It has intermediate kinetics. They are neither slow or fast. So intermediate kinetics. So in terms of potency, class 1C is more potent, followed by class 1A, class 1B, in terms of the potency. Any question up to this point? Any question up to this point? Any question? I should move on. So these are additional advantage of certain medication. For class 1A medication can also block potassium channels, If they are blocking potassium channels, who can tell me what could happen?
They prevent the myocyte depolarization.
So if they are blocking it, it means that they will prolong what? They will prolong the refractory period. They will prolong the refractory period. So they will be prolong the refractory period of the fast channel tissues. Is it clear? Class 1A will also block potassium channels. When you are blocking the potassium channels, they will also, especially when you have the repolarization, they will affecting the repolarization, and therefore the refractory period will prolong. So these are class 1. The most difficult class is class 1. And it's not common, we don't mix them. It's not common. Prokinamide. It's not common. So if I ask you, even the dose of prokinamide, it will be quinidine. If I'm asking you about the dose of quinidine, because it's not common. But you could be asked about, say, flukinamide. Which class is under flukinamide? Which class is under? It's a question. MCQs, anything can come. So flukinamide, you should know, is in class 1C. So note them. Let me move on quickly to to class 2. Class 2. So class 2. The class 2. Class 2. Class 2 is under which medication are in class 2?
Beta blockers.
So class 2 are beta blockers. Beta blockers for class 2. And listen, beta blockers, class 2 drugs predominantly affect slow channel tissues. Class 2 medication, which is a beta blocker, predominantly affect slow channel tissues. So what are the slow channel tissues?
SA node and AV.
SA node, AV node. SA node and AV node, slow channel tissues. And therefore, when a patient comes with assuming sinus tachycardia, nodal tachycardia, then you will not be thinking about giving sodium channel blocker, membrane stabilizers. As membrane stabilizers affect the fast channel tissues. I don't know whether you are getting. Are you getting it?
Yes, please.
And therefore, patient coming with tachycardia, sinus tachycardia, you think about giving what? Class 2, which is a beta blocker. And this would decrease automaticity. This will slow down conduction velocity. And this will prolong refractoriness. When I say it will decrease automaticity, what does it mean? Automaticity, what does it mean? Automatic. It will decrease. When you give beta blocker, it will decrease the pacemaker activity. Automatically, that's why we are using that word. Automatically, the synuclein node will release what? Impulses. So, when you are giving beta blocker, it's going to hit on synuclein node and AV node, the effect. So, if you have sinus tachycardia, the best medication is to go in using what? The beta blockers, because they predominantly affect the slow channel tissue, which are SA node and AV node. So when you use the beta blocker, it will decrease the pacemaker activity. So it will also slow down conduction of impulses in SA node or AV node. And because it's doing that, it will prolong refractoriness. To prolong the refractoriness. You get it. So when a patient comes with, say, tachycardia, sinus tachycardia, the refractoriness is shortened. When a patient is having tachycardia, the refractoriness is shortened. So you do this to prolong. You give the beta blocker to prolong the refractoriness. So beta blocker will do this. And when you use the beta blocker, at the end of the day, I am saying this, whether you would appreciate what I'm saying. At the end of the day, it would slow down the heart rate. Slow down the heart rate. Or it will prolong the PR interval. The PR interval will be lengthy when you use the class 2. Does it make sense? Who can explain why I'm saying that the PR interval will be lengthened?
So, the PR interval will be lengthened because now the beta blocker is reducing the pacemaker activity, and we know the sympathetic stimulation causes impulse to start generating from the pacemaker to the AV node and to the ventricles. So in so doing,
take your time. Take your time. You have that idea. This is something I have to work on. You have that idea. So take your time to answer it. I am saying that PR will be lengthened. PR interval will be lengthened. When you get it right, I'll tell you.
Okay.
Mm-hmm. PR. So, I'm saying PR will be lengthened.
Okay. So if we give beta blockers, the PR interval will be lengthened. Mm-hmm. And this is because we know the sympathetic stimulation can initiate the pacemaker activity, and pacemaker activity sends impulses to the AV node, and from the AV node to the ventricles. So if you are blunting the sympathetic activity, especially in the slow conducting tissue such as the SA node, we expect that
this is my problem. Have you seen? You could go straight to the point. But I have stress on one point. I'm stressing on this, that there will be PR prolongation or PR interval will be lengthened. Where do you have the PR? Then you are still talking about sinoatrial node. Steve, I want you to get something. Well, when I'm talking about PR, where will my mind? Where will your mind go? So when you are talking about PR.
So this is the time it takes impulses to travel through the AV node.
So it's the AV node that you need to target. But you were lumping them. Talking about sinoatrial node, talking about this. Do you get it?
Yes, please.
So we are talking about, please learn about this. The moment I mention PR, now we have passed the sinoatrial node. So I'm not going to go back to the sinoatrial node. PR is talking about impulses via AV node. And because beta blocker would have effect on the AV node, it's going to reduce what? It's going to slow down velocity, conduction velocity. Impulses via this will be slowed down. So it's not a matter of talking about sinoatrial node. Please. I don't know whether you are appreciating it.
Yes, please.
I said it's what? It's the PR. And the PR is impulses transmission via the AV node. So if I'm talking about length in PR, and because the beta blocker would affect the slow channel tissues. And when it affects the slow channel tissues, it reduces or slows down conduction velocity along that pathway. If you are talking about sinoatrial node, then we're talking about slow down the pacemaker activity. There's also conduction velocity, slow down conduction velocity. I'm talking about PR. PR is talking about AV node. Conduction via the AV node will give me that PR. So if I want you to explain, stick to that. Is it clear?
Yes, sir.
Good. So beta blockage, the beta blockage will be used to manage sinus tachycardia. Sinus tachycardia. Let me ask you, can you use beta blockage to manage atrial fibrillation? Yes or no? Can you use beta blockers to manage atrial fibrillation?
Yes, please.
Why yes?
No, sir.
Hello.
Hey, no, sir. I see say a book. Who is beating you? Can we use? Can you do the explanation for me?
Yes. Because because even though the
You said
atrium,
yes or no?
yes, yes, even though the atrium contains the fast sodium channels, and that's where the generation happens, because the impulse has to go through the AV node. The beta blocker can inhibit the influx of the impulse through the AV node, and then help to control the AFib. And so even though there are multiple firing from different foci within the atrium, the impulse has to go through the AV node. So if we are able to slow down how the impulse goes through the AV node, we can help with the controlling of the AFib. That's why the beta blocker can still be relevant in the management of atrial fibrillation.
You're perfectly right. Perfectly right. Perfectly right. So we can still use beta blocker. Why? Because these impulses will go through the AV node. These impulses, these chaotic impulses will go through where? Go through the AV node. And if we don't manage these chaotic impulses going through the AV node, it means that we are not going to be getting chaotic contraction of the ventricles, and that would affect the cardiac output. So we can still use. So we can use beta blocker for supraventricular tachycardia. Use supraventricular tachycardia. You could have atrial failure. You could have sinus tachycardia. All this will be under supraventricular tachycardia. Examples of this beta blocker. We could have atenolol, we could have carvedilol. We use all this propranolol to manage arrhythmia. Class 3. Class 3. This class is called what? Who can tell me?
Potassium channel blockers.
Come again.
Potassium channel blockers.
So class 3 is potassium channel blockers. Potassium channel blockers. Class 3. Potassium channel blockers. So who can tell me the effect of this? An example of class 3 medication is what? Example of class 3 medication is what?
Amiodarone.
Amiodarone. one of the best medication arrhythmia is amiodarone. Amiodarone class 3. Potassium channel blockage, amiodarone. And if I say this class of medication, listen, this class of medication would affect, the reason why it's good is that it affects both the slow and fast channel tissues. It affects the slow and fast channel tissues. Affects the slow and fast, so it can affect the atrial, it can affect the ventricles, can affect an atrial node, it can affect what? AV node. It affects both. So if I say, who can explain this to me? So if I say that this class will prolong the action potential, duration, and the refractory period, will you side with me? This drug, because it's affecting slow and fast channel tissues, it will prolong the action potential and the refractoriness. True or false? Hey, can you hear me?
Dr. Kaka, please, I will side with you.
So
There
explain.
reason being that the potassium channel, when the potassium channels are blocked, it will increase your repolarization. And if your repolarization is increased, it will have an effect on your refractory period. And in a sense that your refractory period will also increase. And the generation of your action potential will also be affected.
So if I'm saying it to prolong the action potential, what does it mean? It means that the depolarization and repolarization times will be prolonged. The depolarization and repolarization time will be prolonged. Will be prolonged. And when you prolong this, because you are prolonging this, refractory period will be prolonged. And there was something about, I didn't talk about, there's something about this class of medication. This class of medication, who can tell me one disadvantage of this class? Just application. We have touched on that. Application. Who can tell me one disadvantage of this class? Have you? Amiodarone. Very, very important. When we're learning about the thyroid, we said that amiodarone, one of the medication that could cause either hypo or hyperthyroidism. Hypo or hyperthyroidism. Amiodarone. So one of the best, who can tell me, if I'm asking you, there's one danger in using this. Amiodarone, you can tell me application.
I think they cause hepatotoxicity to the liver.
In terms of, we are talking about cardio. One danger. I am saying prolonged action potential. Something should click. One danger in cardio.
They are also pro-arrhythmic.
They are also pro-arrhythmic. And one danger will be what? Because of the action potential, prolonging the action potential. What is the danger?
Tosaris with the point.
You are right. You are right. But I will come to that. But the predominant effect I was expecting you to tell me is the QT interval prolongation. QT interval prolongation, because it would prolong the action potential duration. Do you understand? QT interval prolongation. There's QT interval prolongation for this medication. And another thing, there's a risk. There's a risk. And if you could explain this, I'll be very happy. Mostly, it affects the potassium channel. It's block the potassium channel. If it's blocking the potassium channels, it will be affecting the ventricles more, predominantly more. But it has the ability to block, but predominantly to block the potassium more. If it's blocking the potassium, then it will be affecting the ventricle. So there could be a risk of ventricular pro-arrhythmic effect. It could have this ventricular pro-arrhythmic effect. That could be ventricular something, could cause ventricular something, because it's blocking more of potassium, blocking of more potassium. And because of that, there's one type of arrhythmia called torsade de pointes. Torsade de pointes. There's one arrhythmia called torsade de pointes. What is that? So amiodarone or class 3 will cause those torsade de pointes. Torsade de pointes. What is that? This is something. What is this? What is this?
So, sir, please, there is a twisting or rotating of the QRS complex on the ECG.
There's a twisting and rotating. What does it mean? What does it mean when you say there's a twisting and rotation? What does it mean? What does it mean when you say there's a twisting?
I think there's a severe damage within the cardiac myocytes on the myocardium.
Maybe I also didn't know. Good, my good. Hey, maybe I'm also didn't know. Coco. When you talk about Tosadi pointers, it's talking about when we have variation in QRS amplitudes, QRS. QRS. So when there's different amplitudes of QRS, so you could have one amplitude like this. You could have another QRS amplitude like this. You could have another amplitude like this. You have another amplitude. And when you have variation in different amplitude of the QRS complex, when we have this, then we talk about Tosai pointers. And because class 3 is affecting the sodium channel, predominantly is affecting the sodium channel, you could be giving you this variation. So when you are having a variation of QRS complex, the amplitude, this is one, this is another, this is another, this is another, different amplitudes of QRS complex, we term it as Tosai pointers. Please, is it clear? Is it clear?
Yes, please.
Okay. So the last class, and we call it a day, the last class, and please note this, class 2 beta blockers, they affect the slow channels. Class 3, they primarily affect the potassium channels. Predominantly, they affect the potassium channels. And amiodarone, the best medication, amiodarone. Why? Because it affects both the slow and fast, but predominantly it does affect the calcium channel. The calcium channels affect that. And when you affect that, it could lead to side pointers because it could affect the variation, the QRS complex, could affect the variation of the QRS complex. The last class, which is class 4. Class 4 is what?
Calcium channel blockers.
Calcium channel blockers. The calcium channel blockers are class 4. And what type of calcium channel blockers?
Non-dihydropyridine calcium channel.
Non-dihydropyridine calcium channel blockers. Good. Good. What would be the effect of these class? Who can tell me the effect of which? Which area will it affect? Whether slow channels or fast channels? Calcium channel blocker used in arrhythmia, and it's not any calcium channel blocker. It's the non-dihydropyridine calcium channel blocker. In this non-dihydropyridine calcium channel, would affect which part of the heart, or which type of tissue will it affect? Hey, am I muted?
No, sir.
No, Doc.
Please.
Can hear you.
Answer me. I can't hear.
Slow channel tissue.
It would affect the why slow channel tissue. It should affect the slow channel tissue. So these things are healthy. And therefore, if you know that calcium channel blockage, the non-dihydropyridine, would affect the slow channel tissues, then if there's sinus tachycardia, you'll be using what? Calcium channel blockers to do that. So it does affect the slow channel tissue. And what it does is that it will depress the calcium dependent action potential in slow channel. When you say this, you get confused. But when you sit down and break it down, you appreciate it. It will depress the calcium dependent action potential. So if the action potential, the action potential, you know, calcium is involved in these action potential. Calcium is involved in these action potential. So if this would depress, it will depress the calcium dependent action potential. What will happen is that it will decrease the rate of, it will slow down the conduction velocity. Yes. It's blocking the calcium. Conduction will be slowed down. It will prolong the refractoriness. It will slow down the heart rate. And PR interval will also be lengthened. And the pacemaker activity will also be slowed down. If affecting the slow channel tissue, the rate of the pacemaker activity, which is automaticity will be slowed down. That is, the pacemaker activity will be slowed down. To slow down conduction velocity, to prolong the refractory period, slow down the heart rate. It will also prolong or lengthen the PR. Examples of this class. Who can tell me one or two examples of this? Come again.
Verapamil.
Verapamil and what?
Diltiazem.
Diltiazem. Verapamil and diltiazem. So this is. So we use this to manage supraventricular tachycardia. We use this to manage supraventricular tachycardia. We use this to manage supraventricular tachycardia. Any question? Okay, so I'll be doing atrial fib tomorrow. I'll do atrial fib. Then I'll move on to IBD. Go and learn. Go and learn. See you tomorrow.
Hello, Dr. Tatakar. Please, I have a question.
Okay.
So I came across Sotalol as one of the antiarrhythmic medications. And some of them classify it as class 2.
2 and 3.
Yes, please.
Mhm.
I wanted to know why it could be in both classes.
Because of the effects, it will do that for class 2. It will do that for what? Class 3. But normally, it's more of class 2, but it will do that for class 3. We are saying for class 3, we are saying for class 3 it's more of what? Potassium blockade. But it could also affect, so it can affect the other channels. We have slow channels and fast channels. So if you have an agent that could also have additional benefit, when we are talking about class 1A, we said that class 1A can also affect what? Potassium. Do you get it?
Yes, please.
But predominantly it's not for that, but it has that benefit of that. So you could have in a class, but you could have additional benefit of doing other things. That is why you could be classified, looking at what that class does. And if you are able to also do that, you could classify. So class A has effect of blocking potassium. So if I'm not having any amiodarone and I want to consider a class of medication, I could look at class 1C. So class 1A and choose class 1 because it has that some amount of that, but predominantly it's not for that. Do you get it?
Yes, please. Thank you.
Okay, so go and continue learning, go and rest and continue your learning. If you don't have any question, then let's call it today. Hello.